So we're joined today by Dr. David Spriggs, and you're a medical oncologist, and you're also heading a ovarian cancer program as well.
Well, the Sloan Kettering is a big place. There are 14 medical oncologists now practicing GYN cancer, of course, mostly ovarian cancer. And I'm one of the originators of that group, but the group is now led by Dr. Carol Agajanian.
Mm-hmm.
And I have a research program that I lead in immunotherapy and the development of antibodies against ovarian cancer. But I am not the leader at this point.
Okay. And so we'll dive right on in. If you could tell us a little bit about, what your research focuses on.
Mm-hmm. So our research is directed at the properties of the CA-125 molecule, which is scientifically called MUC16. And it has a variety of properties, including the fact that it can be detected by the CA-125 screening test that Dr. Bass and others developed back in the 1980s. But it is it has many functions besides being a convenient handle for identifying early cancer recurrences, or can be used in a variety of other ways.
And in reference to immunotherapy, it's relatively new and emerging, especially when it comes to ovarian cancer. Can you tell us a little bit about what immunotherapy is, and what should the survivor community know about it?
Okay, well, if one thinks about immunotherapy, it's been around for a long time. It has become more recognized because of certain successes, mostly in diseases other than ovarian cancer. It has been reasonably successful in melanoma, for example, which is where the original developments occurred. It's been recognized as effective in things like bladder cancer, lung cancers, certain kinds of endometrial cancer. It has been of limited value so far in ovarian cancer, but it's still in the early stages of application in ovarian cancer, and there's a lot of active clinical research ongoing right now in that field. But I think that there are no established treatments immunotherapeutically in the ovarian cancer setting, either in the primary treatment or even in recurrent disease, where it has become FDA approved and is really used widely. So there are still many questions to answer about whether or not this is a form of therapy that's going to be useful in ovarian cancer and helpful to ovarian cancer patients.
So that was kind of my next question as to whether it was effective for ovarian cancer, but it seems as though it's still in its early stages.
Well, I think what the survivor community should know is that it depends on what you call effective. Mm-hmm. The improvement rate is, at this point, certainly less than 20%, and in some studies it's been less than 10%. So it has been not nearly as effective as you might expect from the early data in melanoma and other things. And it doesn't mean that it won't be, but in melanoma, even one drug for one immunotherapy drug in melanoma can be effective in half the patients. And we're not nearly at that point yet in ovarian cancer survivors.
So can you tell us about immunotherapy when it's used in combination with chemotherapy?
Well, let's take a step back and let's say, so what have we learned about immunotherapy? Now I'm talking primarily about checkpoint inhibitors, ipilimumab, nivolumab, and members of those families. And then I know that you're also going to be speaking, Dr. Odansi, about activating tumor T cells taken from the patients themselves. And in all of those cases, the thing that seems to be the most promising is to try to identify what we call neoantigens, where mutations cause the formation of new proteins, and those proteins become antigens, which are like handles for the body's own immune system to grab a hold of and do effective fighting of the cancer. And what we've found is that the number of these neoantigens seems to be importantly related to the likelihood of success. So the diseases in the gynecologic community where we've seen the most success with immunotherapy tend to be endometrial cancer, where there are loss of the mismatch repair proteins, and as a consequence there are more mutations. And there are suggestions that they're because of the ineffective DNA repair associated with the BRCA1 genes, BRCA1 and BRCA2, that population may be poised to benefit more from immunotherapy relying on T cells than the average ovarian cancer. So now to get back to the question you asked, well, what about in combination with chemotherapy?
Right.
The idea with chemotherapy is that it kills some of the cancer cells and can release new antigens that can become targets for the immune system. So one of the ways that immune therapy is being explored in ovarian cancer is to combine some form of chemotherapy or even radiation therapy, where it showers the immune system with new epitopes of proteins which are not normally seen by the immune system, and it allows the body to develop an immune response to those new antigens. And so the combination with chemotherapy and with immune therapy has been something that has been used in experimental models to show that there's some effect. And those studies are now ongoing to try to see whether they're going to be successful. But there are, at this point, no established combinations that have proven benefit for an ovarian cancer survivor combining those kinds of treatments.
And that was actually my next question, is if there was a significant difference in survival for patients and any of those benefits. So,
well, the only thing we can say so far is that the tests haven't been that wonderful, and so that's been in order to get a drug approved, it has to be either surprisingly effective by in a small study, or proven effective in a large study against standard treatment. And neither one of those things have happened yet in ovarian cancer survivor treatment studies. So they are still good ideas, but we know that the outlook for a woman who has a tumor with lots of T cells in the biopsies that are taken, or in the surgical specimens that are taken, has a better outlook than women without a lot of T cells. So there are tantalizing reasons to think that this ought to be useful, but we haven't gotten there yet.
And that's understandable. Everything takes time.
Yeah.
What about toxicity and side effects of immunotherapy?
Well, I think that immunotherapy is not a free lunch.
Right.
That there are clearly patients who get side effects, and it is some of the side effects are more severe at this point than chemotherapy. And there can be damage to the kidneys, the pituitary gland, the thyroid gland, and some of these things are reversible and some of them aren't.
Right.
There also can be episodes of colon inflammation and pretty much any kind of inflammation you can think of. And when you use immune therapy, you've really just taken the brakes off the immune system. Now, women are much more prone to all of the rheumatologic diseases, whether it's lupus, arthritis, whatever. All of those things are a reflection in part of the immune system interacting with normal organs and causing damage.
Mm-hmm.
And when you take the brakes off, that can happen. Now, the incidence of those things is below 10% and often below 5%. But it can diarrhea, abdominal pain, colitis are the most common, but you can see changes with the lung or the joints or the endocrine system are all things that we watch for. So that these aren't necessarily things that a patient would immediately know, but it's part of the monitoring process that goes on with any immune therapy, is to pay attention so that if the immune cells are attacking normal organs, that activity can be shut down either with holding back on the drug, giving prednisone, whatever it takes in order to make this side effect go back into the background.
And you touched on, there are some side effects that are reversible, some that are non-reversible. For our specific survivor community, is there something that they should, also be aware of when opting for immunotherapy?
Well, I think that this is why one has to read the consent forms and understand the possibilities of benefit versus the risk.
Mm-hmm.
And I think that most of the side effects are reversible, but sometimes the damage to the pituitary, for example, where you would then need to take hormone supplements for the rest of your life, may not be reversible. And so that's much more common with ipilimumab than it is with any of the PD-1 inhibitors. And so a lot of the proliferation of checkpoint inhibitors really is focused on the PD-1 antagonists because those are drugs that have a more favorable profile than the anti-CTLA-4 drugs like ipilimumab, which tend to have a more toxic profile because they really take a lot more of the brakes off, and so you get a much less controlled kind of response.
So can immunotherapy be used in newly diagnosed patients, or is it more beneficial to treat recurrent ovarian cancer?
Both of these things are being studied.
Mm-hmm.
And there are studies, for example, looking at an immunotherapy in combination with carboplatin and paclitaxel in the frontline setting, with the idea that if you can get an immune response started by killing some of those cancer cells, which we know is very effective with standard chemotherapy, that you can precipitate those kinds of longer-term benefits. But of course, the better the stage of the cancer at the time of original diagnosis, and the higher the risk of cure, or the higher probability of cure, the less acceptable unknown risks really become. And so the migration of treatments in ovarian cancer and most other diseases starts with very advanced cancer and is gradually moved back closer and closer to frontline treatment as we understand what are the characteristics of the patients who are going to improve on that treatment, what are the risk profiles, and can we get it to the point where it's so safe that even if half the women are looking at potentially curative treatment, it still is an acceptable risk to go forward.
Can you tell us a little bit about kind of, if you can put on your psychic hat
Mm-hmm.
for a moment, and what the future vision of this treatment approach would be?
Mm-hmm. Well, I think that it will always be, I believe, more of a niche treatment for
Mm-hmm.
this disease as opposed to tobacco-related cancers, for example, where they have a very high mutation rate and a very characteristic mutational load. And so small cell lung or non-small cell lung cancer is a place where we have a surprising amount of benefit seen. With melanoma, much of that damage comes from the sun damage that leads eventually to melanoma. In diseases like ovarian cancer, which is more likely to be a disease of reduplications and deletions than it is of point mutations, I think it will be something that will require more sophisticated development in order to get it to the point where it's really benefiting more of the patients. And it may, the medicines that we currently have by themselves will probably not move the needle very much. And what we're going to need is we're going to need either combinations of these checkpoint inhibitors or other mechanisms by which we can raise the antigenic presentation of ovarian cancer proteins to lead to a better result.
And that's something we seem to hear quite a bit, and even all of these interviews, is that this is not your run-of-the-mill kind of complication, because it has unique mutations, and you guys are having to kind of attack from different angles in a lot of the other research. So with all of that, it can be a little overwhelming and also disheartening to those that are currently diagnosed with ovarian cancer, who are undergoing treatment. What would your message be to those who are currently undergoing treatment?
I would think that the survivors should really focus on the fact that in every 5-year period since 1970, the survival of women with ovarian cancer has increased. And it has increased during times when new drugs are developed, like cisplatin and then carboplatin and paclitaxel. And it has also increased in times when, if one looks at what is in the pharmacopoeia for ovarian cancer treatment, it doesn't seem like it changed very much, but it's still getting better a little bit. And so right now, the average with the best clinical trials that are being done is over 80 months of average survival, which means half the people are doing better. But of course, in order to know that, those are women that were treated at least 80 months ago.
Right.
And so much of the progress that's happening now will not show up until 2025. And so I think that what I tell my own patients is that it's important to focus on the moment.
Right.
It's important to listen closely to your doctor and get the best recommendations. And the treatments are also getting not only better, but less toxic.
Yeah.
And I think that we're going to see women living longer and better with ovarian cancer over the next decade, just as we did over the last decade. And I think that if one looks at diabetes, one looks at heart disease, we've not cured those illnesses. We may not cure ovarian cancer, but what we are doing is we're turning it into a chronic disease where women can live 10 or 20 years with ongoing intermittent treatment, raise their families, attend to their jobs, do the things that they have prioritized. And yes, they have to take time for the treatments, but the treatments, I think, we're trying to make them less onerous.
Right.
We're trying to make the time in between the treatments longer while we wait for those things which are really going to move the needle on the cure rate.
Right. Well, that's a great message, right? Because every inch is going to bring us closer to a mile.
Mm-hmm.
So.
And I think that there is a lot of good news in the way ovarian cancer patients are being treated, how they're going about their lives, and that's something that people really need to appreciate, because it's a long road.
And my final question to you would be about ovarian cancer awareness.
Mm-hmm.
Just like you mentioned, a lot of other diseases are out there on the front lines. What would you have to say about raising awareness for ovarian cancer?
I think ovarian cancer patients benefit all of us by speaking out. I think that if one looks at what's happened in prostate cancer, look what's happened in breast cancer, those are diseases where the very chronicity of those diseases has led to a very large and vocal advocacy group on the part of the survivors. And just like it was true for HIV, those survivors really help us in terms of generating awareness, in terms of uh, helping to raise research dollars, and in terms of supporting each other as they go through what can be a very difficult and devastating illness, so that each one of them can is able to really live a very full life through that kind of support. And you see that with the survivors now, and I think we'll see more and more of that as the survivors for ovarian cancer become much more numerous, and they're very active and aware, and it makes a huge difference to the entire field.
Well, thank you so much, Dr. Spriggs. This has been a great conversation, and I think very beneficial for the survivor community.
Okay, well, thank you very much.
Thank you.